Good evening, everyone. The topic I'd like to share with you today is about intracystic hemorrhage and its management during ultrasound-guided percutaneous microwave ablation for cystic cell nodules. As many of you may be aware, cell nodules are common. Being detected is up to 65% of the general population. Many of these nodules are pure cystic or predominantly cystic. According to the guidelines of American Cell Association, cystic nodules are considered to be of negligible malignancy risk. However, cystic cell nodules still require treatment in some cases, such as those with rapid growth, aesthetic disturbances, or local compressive symptoms, or in patients who are worried. At present, treatment options include simple nodular aspiration, ablation, or surgical resection. Aspiration can be performed easily, but recurrence rates are high, observed in 60 to 90% of patients. Surgical treatment is more definitive, but might be associated with scarring and more complications. Ablation has been increasingly accepted as the best treatment. Okay, let's go on. Ablation has been increasingly accepted as the best treatment for cystic cell nodules. Currently, the following types of ablation therapies are used to treat cystic nodules, include ablation, laser ablation, radiofrequency ablation, and microwave ablation. Microwave ablation is a local thermal ablation technique that has fast heating speed, strong coagulation ability, and large ablation zoom, and have become a major method in heat ablation therapy. It's effective for treatment of cell nodules worldwide. We found that intracystic hemorrhage appeared occasionally when ultrasound-guided percutaneous microwave ablation was used to treat cystic cell nodules and interfered with treatment. In order to avoid intracystic hemorrhage and improve the efficacy of ultrasound-guided percutaneous microwave ablation to treat cystic cell nodules, we analyzed the causes of intracystic hemorrhage and explored the corresponding solutions during ultrasound-guided percutaneous microwave ablation for cystic cell nodules. A total of 87 cystic cell nodules in 59 patients were treated with ultrasound-guided percutaneous microwave ablation in our hospital. The characteristics of patients were shown in this table. Our nodules are examined through preoperative or postoperative ultrasound-guided fine needle aspiration cytology, and were confirmed as benign pathologically. The 59 patients with one or more pure cystic nodules or predominantly cystic nodules were selected based on the following inclusion criteria. Total include 4 points, like this. The exclusion criteria include 2 aspects. The equipment we used, just like this GE Logic E9 ultrasound diagnostic device, Nanjing Yigao multifunctional microwave therapeutic instrument with microwave ablation needle antenna. This is the ablation standard procedure. Here is about follow-up. The results. 9 cystic cell nodules in 9 patients presented with intracystic hemorrhage during ultrasound-guided percutaneous microwave ablation, giving an incidence of 10.3%. Intracystic hemorrhage occurred in nodules measuring 3.1 to 4.8 centimeters. 77.8% of intracystic hemorrhage occurred in women aged 40 to 60 years old. All intracystic hemorrhage occurred in pure cysts, although with cystic components over 80%. Middle-aged women with larger nodules were more prone to intracystic bleeding. In this figure, we can see a thyroid cystic nodule prone to intracystic hemorrhage. The characteristics include bigger, more cystic components, peripheral blood flow, and a still hemorrhage in the nodule. Intracystic hemorrhage occurred after aspiration of cyst fluid and before microwave ablation in most cases. The nodules that had shrunk gradually enlarged again under ultrasound monitoring. Sometimes the enlargement was visible to the naked eye, and in some special cases, bleeding points and blood flow could be seen. Fresh blood was found when shocked again. Bleeding was confined to the cyst and did not affect other tissues. The management. When intracystic hemorrhage occurred, the operator stopped the procedure. Local compression was used to stop bleeding for 3 to 5 minutes. If the bleeding stopped, the provider aspiration and ablation steps were repeated. If bleeding persisted or recurred, a 20 milliliter syringe and the ablation needle were placed into the cyst at the same time. Aspiration, observation, searching for the bleeding point, and ablation were performed simultaneously. Treatment of possible bleeding sites near the cyst capsule should be emphasized. The hemorrhagic vessels were closed by heat ablation. In our study, all cases of intracystic hemorrhage was stopped in the first place. Intracystic hemorrhage hematomas formed locally when several cases took too long to treat. Intracystic hemorrhage increased the complexity of the operation, and the operation time for each nodule was significantly longer. Intracystic hemorrhage caused more significant post-operative symptoms and extended hospital stay. Intracystic hemorrhage affects treatment effectiveness of microwave ablation for cystic cell nodules, as shown in this table. All patients in the control satisfied with the treatment effect. One patient in the bleeding group after 2 months. Due to unsatisfactory, no other serious complications were observed in their group. Many studies were active technique for nodules. including cystic and solid nodules. In our practice, we found that intracystic hemorrhage occurred occasionally when we treat celled cystic nodules with microwave ablation. Intracystic hemorrhage interfered with the treatment and had an adverse impact on the eventual efficacy. So clinicians should pay more attention to and try to avoid intracystic hemorrhage. We analyzed the causes of intracystic hemorrhage. May include 3 points. The first one, there was intracystic hemorrhage originally, and the bleeding stopped as the pressure increased due to bleeding in the closed capsule. The ablation treatment time was too soon after the original bleeding time. During the ablation process, the cystic fluid was suctioned and the local compression relieved. This caused the original bleeding site to bleed again. The second one, there were many large blood vessels around the cyst. The needle easily damaged the blood vessels and caused bleeding. When cysts shrink by puncturing and suction of cyst fluid. The third one, improper procedures or inadequate skill or experience of the operators were likely to cause intracystic hemorrhage. In order to avoid intracystic hemorrhage, we should do the following. Firstly, before using microwave ablation to treat cystic cell nodules, a detailed history should be taken, including recent changes in the size of the nodules, with or without pain. Microwave ablation should be postponed if there was a recent intracystic bleeding. The ideal treatment time is 3 to 4 weeks after the anterior neck pain disappears. Secondly, the needle should be as far away from the capsule wall as possible. When puncturing and aspirating cyst fluid, operators need to adjust the needle position at any time during aspiration of the cyst fluid and the cyst shrinks. Thirdly, CDFI should be used to observe carefully the blood flow around the cyst before ablation. Large blood vessels should be avoided in advance. Fourthly, operators should be proficient in basic techniques of ablation, such as the moving shot technique, the multiple overlapping shot technique, the hydro dissection technique, and the leverage pry-off method. Insufficient experience or unskilled operation can easily lead to failure of treatment, and even the risk of uncontrollable bleeding that requires conversion to open surgery. There are still something to pay attention. It's important not to panic in this situation and calm the mood of the patient. The operation must be performed and accurate. Tumor if too much time is taken to deal with bleeding, which will affect the treatment outcome. There is no need to suck out all the cystic fluid. Operators should be careful to ensure safety and to prevent other complications caused by rushed operations. Currently, some reports still recommended external ablation as a first-line treatment for predominantly cellular cystic nodules. In our study, the cystic volume gradually reduced after microwave ablation. Compared to the baseline, microwave ablation can achieve nearly 84% of the volume reduction and improve the clinical symptoms. Meanwhile, the adverse effects are negligible. So according to our experience and other research results that microwave ablation for cellular cystic nodules achieved good results, and the relapse was difficult. Sclerotherapy to treat cellular cystic nodules, and so far the results are better. In summary, we hope that our report will help surgeons take precautionary measures to minimize the possibility of intracystic hemorrhage. This will make microwave ablation more effective for clinical treatment of cellular cysts. Oh, thank you.